Welcome, everyone. This is the last in our spring 2017 series of geriatric healthcare lectures, sponsored by the Northwest Geriatrics Workforce Enhancement Center. My name is Barbara Cochran. I'm from the DeTournier Center for Healthy Aging and the School of Nursing, and representing the Northwest GWEC today. We're very happy to have Susan McCurry doing this last talk, the best and the brightest, right? She is a clinical psychologist specializing in gerontology and geriatrics. She's been involved in research and clinical practice with older adults for over 25 years. Received her PhD from the University of Nevada, Reno, where she was trained in contextual behavioral science. And as part of the UW Research Group on Aging, she has worked to help develop, systematically evaluate, and translate non-pharmacological interventions to improve quality of life for older adults, including persons with cognitive impairment. Therefore, you can see she brings great expertise to this talk. She has authored over 150 scientific articles and peer-reviewed chapters, books, and an APA video designed to help family caregivers and healthcare professionals provide more effective, compassionate care to cognitively impaired individuals and caregivers. And she's been an investigator on 31 federal, state, and foundation grants related to aging and dementia. Her research has focused on development and evaluation of training programs for family and professional staff, working with persons with cognitive impairment, including homeless individuals. She's examined the environmental, behavioral, and psychosocial factors associated with successful physical and cognitive aging, and has assessed and treated sleep disturbances in older adults with comorbid medical conditions, including Alzheimer's disease, chronic pain, and menopausal vasomotor symptoms. And so you can see she just brings a wealth of expertise to this topic, and we're looking forward to hearing all about maximizing quality of life for older adults across the cognitive continuum. Welcome, Dr. McCurry.
Thank you very much. So I must warn you, my audience, that this is a new foray for me, giving a talk this way. I'm normally up on a stage and I pace. So I may be waving my hands. I'll try to keep control of what I'm doing here, but I also don't see a clock in the room, so someone is going to have to help me stay on time, please.
There is one right behind you.
Well, but that's right behind me. So
Screen might have a timer on.
I don't see one, but anyway, let's just move along. So the arrow key, oh, there it is. Okay, so I don't know how many of you know who this person is. This is Auguste Dieter, who was the first individual that was diagnosed with Alzheimer's disease. Auguste was in her late 40s, I think, when she first developed symptoms of dementia that became severe enough she had to be institutionalized. And after she died at the age of 56, Dr. Alzheimer's, in a brain autopsy, discovered the characteristic plaques and tangles that we now associate with Alzheimer's disease. And about 100 years later, actually, there were scientists that looked at samples of those same brain tissues and discovered Augusta also carried the presenilin 1 gene, which we now know is a common cause of early onset Alzheimer's in individuals. So at the time, Augusta was diagnosed, and for many decades after, it was believed that the kinds of disease she had, this Alzheimer's disease, was an early onset condition, and that the types of dementia older people had was in fact different. And we now know that's not the case, that Alzheimer's disease is the most common cause of late life dementia as well as early onset, and that in fact as people grow older, they are more likely to develop Alzheimer's disease, and so the rates of Alzheimer's are growing exponentially around the world because people are living longer. Oops, I keep hitting the wrong button. Although Alzheimer's is the most common cause of dementia, there's, this slide says more than 70 conditions that can cause dementia. It's probably closer to 100 now that are known. The most common, again, still being Alzheimer's. The other most common irreversible causes like strokes and vascular disease, or dementia with Lewy bodies, Parkinson's disease, frontotemporal dementia. These are mostly conditions that are age-related as well as Alzheimer's. And the fact that you have one condition doesn't protect you from having any of the others. And so it's not uncommon for people to have multiple things that are causing them to decline as they age. But what we've learned is that many of the diseases, for example, Alzheimer's disease, the symptoms in the brain that cause dementia clinical signs are likely starting to develop much younger than we see the symptoms. So people are probably in their 20s and 30s already starting to get some of the pathological changes associated with Alzheimer's disease. And these are going to progress very slowly. And when they do become symptomatic, the severity of symptoms that people have are going to also vary from being very mild, almost preclinical, to very severe, where a person needs complete care. And even in cases where persons don't have any pathological causes that we can see at, say, autopsy, they may still be experiencing changes in their cognitive function over time. So what you're seeing is that people are getting symptomatic, at least at a neuropathological level, probably much earlier in age than we can detect it. And then when they begin to have symptoms, the symptoms are all across the continuum. So what this means is that unlike the days when I first started doing this work, it's no longer someone's going to come into your office and they're just going to want to get a diagnosis, you have Alzheimer's disease, and then you're sent on your way. The current thinking is that dementia is a chronic illness, like living with diabetes or living with high blood pressure. And in fact, some of the recent changes in diagnostics really emphasize this continuum from normal brain to severe brain pathology. So for example, DSM-5 has eliminated the term dementia altogether, and they've replaced it with minor and major neurocognitive disorders. So minor neurocognitive disorders are where someone shows a significant decline in their memory or other kind of cognitive ability compared to where they were in the past, but they're still able to function just fine in their daily life. This is kind of like what we call now mild cognitive impairment. Major neurocognitive disorders are where people have that significant decline in cognitive functioning, but also it now is interfering with daily life, and that's like the old dementia term. We're going to still use the term dementia for our purposes here in today's talk. The National Institute of Aging and the Alzheimer's Association also now recognize something for research purposes called preclinical Alzheimer's disease. And that's where they're looking at changes in brain and cerebrospinal or fluid, blood fluid, that these changes might be detectable 20 years or more before a person shows any clinical signs of dementia in their presentation. So the bottom line is, as clinicians who work with older adults and are interested in cognitive impairment, what this means is we are seeing people younger and younger who are either coming in with an actual diagnosis of mild cognitive impairment or maybe even Alzheimer's disease, or who are just themselves reporting that they're noticing changes in their thinking. We're seeing a whole continuum of severity of problems. People may be coming to us very early and wanting help. They may be coming to us brought by family caregivers or paid caregivers very late in their disease. So we're seeing it across the cognitive continuum. And we may be treating people for years. You know, even if someone like myself only works with older adults, if I consider I'll start working with people in their 50s and I may work with people until their hundreds, you could see people for decades. So again, dementia has become a chronic illness, and we, as clinicians working with older adults who are interested in cognitive impairment, are going to see people a long time across a whole spectrum of age and severity. So the question is, what do you do with that? And what I want to propose is the shift that I've made in my own clinical practice that I'm encouraging people to make is start really focusing not so much on diagnostics or on particular pharmacological treatments, although there's a place for those, and I'm not undermining their value and use, but to really start focusing on quality of life, to start thinking about how can we serve the whole person to help them at whatever stage and age they are to have a sense of well-being, satisfaction with life, you know, that they're able to feel they have a sense of some control over how they're living their life. And I'm going to propose today that there are 3 very practical tools you can use in your clinical work to encourage people to start doing things that are going to help enrich their quality of life across the cognitive continuum, and that also are going to be useful for other purposes. And these 3 tools are establishing a stable and sufficient sleep routine, to move your body, kind of get exercising, maintain regular exercise, and find ways to find meaning, purpose, and joy in life. And I picked these tools, first of all, because they're all evidence-based, and in fact, my research group here at University of Washington has been involved in doing research with all 3 of these things, so I just happen to know something about them. These all have very practical implications for your daily work with older clients and for your own lives. For those of you who are aging, which is, of course, all of us, and who are interested in maintaining quality of life and cognitive function as long as possible, they may, in fact, have implications for slowing progression of cognitive decline. And some of what I'll be talking about here today may overlap slightly with things that you've heard from previous talks, for example, the talk that Emily gave last week. But what I'm trying to do is going to be focusing on very practical, clinical things. I'm a behavioral psychologist. You all represent a wide spectrum of other healthcare professions. But I believe many of these tools, you can work with your clients and help them improve their lives using them in your own practices as well. So the first of these is sleep. And sleep is really good, right? You feel so great when you get a good night's sleep. But the thing is, this is something all of us do every day, and a lot of us actually don't know anything about sleep. So I just want to give you a real simple 1-slide primer about sleep. And what that is sleep is caused mainly by the confluence of 2 processes. First is called the homeostatic process. And what that means is the longer you're awake, the more sleepy you feel. So you're more likely to want to nap at 4 in the afternoon than at 10 in the morning if you got up at 8. So its sleep drive increases, need to sleep increases as the day goes by and it's been longer since you slept last. The other process is a circadian process. That's your biological clock. And over the 24 hours, actually 25 hours, we have changes in our body temperature and our hormone levels that work together and impact our tendency to feel sleepier at certain times of days than the other. And when those 2 things are working together perfectly, then we get this good sleep that everybody really enjoys. And the health benefits on this slide of good sleep are obvious. You might notice that many of these benefits relate to conditions that are more common as people age. So for example, older adults are at greater risk to develop diabetes or to have problems with cardiovascular function. And improving cardiovascular function and reducing risk for diabetes can improve not only overall physical health and longevity, but also can reduce risk for things like stroke and sleep apnea and other conditions that can improve our cognitive function. In fact, it's interesting, in recent years, there have been some rat studies that have shown that when we sleep, there's something called the glymphatic clearance system, which causes cerebral spinal fluid levels to increase dramatically in the brain. And these wash away many of the toxins that build up in our brains during the day, including things like amyloid beta, which is associated with increased risk for Alzheimer's disease. And there's been some real growing interest in this relationship, possibly between sleep and Alzheimer's disease. There's this idea that there may be a bidirectional relationship. So when our sleep is poor and our circadian rhythm is out of sync, that increases our risk for having an inflammatory response biologically, which can lead to Alzheimer's disease, pathogenesis, things like deposition of amyloid beta, and that makes the circadian dysregulation in the sleep worse. It becomes this vicious cycle that can potentially, with medications or non-pharmacological treatments to improve sleep, be disrupted. And there's a belief that early on, if we can break some of this cycle, we may in fact not only reduce our risk for things like diabetes and hypertension and other kind of cardiovascular disease, but in also be reducing our risk for development and progression of Alzheimer's disease, which is pretty neat, huh? So the trouble is, unfortunately, as we age, it gets harder to get a good night's sleep. So what this slide shows, that there's the delta sleep way down at the bottom, and it's basically saying that when you're born, when you are in bed, say, 8 hours at night, maybe close to 2 hours of that is going to be deep, restful sleep. And this is where when you wake up in the morning, you feel so good. As we age, and you look kind of on the far right bottom of the slide, by the time you're getting up to 60 and 70, most of us are not getting any of this good deep sleep at all at night. That's not everybody. There's exceptions to all rules, of course, but we are biologically predisposed to not be able to get good deep sleep at night as we age. Our amount of time that we spend in REM sleep, so that's rapid eye movement or dream sleep, stays about the same. What happens is the amount of time we spend in what's called stage 2, that's lighter sleep, right after you fall asleep, gets bigger. And so that means we're more vulnerable to wake up if the dog barks, or if the light's shining in from outside, or if the temperature is too hot or too cold, or you turn over in bed and your osteoarthritis pain tweaks your shoulder. So, and once we wake up, it's harder to fall back asleep. So although there's all these really great benefits to getting good sleep, particularly for older adults, it is harder to get good sleep when we age. So we have to work a little bit more at it. We can't just, my 23-year-old can just shut his eyes and pass out anytime, anywhere. We, as we start getting into our 50s and 60s and beyond, cannot do that, generally. So I would encourage you as clinicians, if you do nothing else, just ask your clients, how's your sleep? Do you sleep well or not? And if they say no, ask them, well, what kinds of sleep problems do you have? Do you have trouble falling asleep? Do you have trouble staying asleep? Just get a sense, or is sleep even an issue for them? If sleep is an issue, you want to ask a few more questions. So, for example, you want to get a sense of, have they ever been diagnosed with a primary sleep disorder? Something like sleep apnea or restless leg syndrome. Sleep apnea is particularly pervasive and underdiagnosed and undertreated, I would say particularly in older women. Compliance with the main treatment for sleep apnea, which is a CPAP machine, is not good. And so, and many people just aren't aware they have it. So if someone's having trouble sleeping, you might, if they have a bed partner, you might ask, does your bed partner complain that you snore at night? That you're not breathing for 15 seconds at a time before you gasp yourself back awake? Or do you notice a person is your client or patient quite heavy and they're complaining about falling asleep during the day? These might be signs of sleep apnea, and it's important to have it diagnosed, because if it exists and isn't being treated, you're running the risk of a person is getting insufficient oxygen in the blood and to the brain at night, which is going to contribute to cognitive decline, can increase risk for strokes and other kinds of vascular disease. And also, they're going to be less responsive to medication or non-pharmacological treatments for insomnia. You should just be aware that if you've got clients who are anxious or depressed, they may very well be having sleep problems as a part of their psychiatric condition. But if they've got high blood pressure or diabetes, or if they're overweight, or if they have cardiac heart disease, they may also be having sleep problems. So again, just ask, particularly if you have clients that have any of these conditions that increase their risk. These are a list of medications that can worsen sleep, and you might notice many of these medicines are commonly taken by older persons. Sometimes a medication can be taken at a different time of day, and it would be less likely to nighttime sleep, and it might be worth having the patient have a conversation either with you or with a geriatric pharmacist or their own healthcare provider about the time of medicines if they think something they're taking is increasing their tendency to have trouble falling asleep at night. Alcohol is commonly misunderstood. People think it's a depressant, so it's going to help you fall asleep, and that is true. But when the alcohol starts burning off a few hours later, you're going to rebound awake, and it's actually going to make your sleep worse and more disrupted. So people who are using alcohol, perhaps to help them fall asleep, ultimately are doing themselves a disservice. And you all may know all this, but many of your patients and your clients do not. Environmental and behavior causes. If people are having trouble sleeping, it's worth just showing them a list like this and asking if any of these things apply to them. The National Sleep Foundation a few years back did a national survey on how many people in the country have their sleep disrupted by pets. And it's like enormous. It's like 45% of us. I know I sleep better when my cats are downstairs, but mostly they're not. Mostly they're upstairs in the house with us. So if people are complaining about having significant sleep problems, take a look at these environmental factors or encourage them to take a look at them. So the point that I just made here is if you are interested in working with your patients about sleep, there's a whole lot of things to ask, right? So what I've done in the handouts that I sent forward as part of this talk was included some things at the end. You've got an appendix. And so there's lists of common sleep measures that are used to describe sleep quality at night, daytime fatigue, to come up with an operational definition of whether someone has insomnia or not. There's recommended resources that people can read, both for clinicians and for people, private persons, lay people. So you can refer back to that, and that'll help give you an idea of if you want to include some sort of a sleep assessment in your practice, maybe ways that you could do it most efficiently for your time. But let's say you talk to your client, you know that they have sleep problems. What do you do now? Well, sometimes all you have to do is just give them a list. These are called sleep hygiene rules, and they're basically common sense recommendations for how to improve your sleep habits and sleep environment that will increase the likelihood you can sleep. Sometimes it doesn't take anything more than that, than to just suggest people to, cut out alcohol after dinner and get up at the same time every morning and, throw the cat in the basement, and that will be enough, and people will begin to sleep well. And as a behavioral psychologist, what I really believe in is helping people take small baby steps towards their goals. So if you've identified there's some things the person's doing, they're sitting in bed at night, playing games while they're like trying to fall asleep, or they're having, 4 glasses of wine instead of 1, and they're finishing up about 10 at night, or they've got that damn cat. Is there one thing you can commit to change this week? Just one thing, and how can I help you get there to take this one step? You don't have to change everything at once. Small things can sometimes make a big difference. If these little simple environmental, lifestyle factors are insufficient for bringing about change, and they often are, then a person may need to do something more intensive, and that may include cognitive behavioral therapy for insomnia. That does not necessarily mean that you have to refer someone to a local sleep lab. You may have sleep practitioners in your area that can offer CBTI, but you may not. There also are very good self-help books and online resources, and again, I've included those in your appendices to check out. But these are just the main components that a CBTI approach involves. I can tell you that cognitive behavioral therapy for insomnia has been shown in many dozens of studies to be highly efficacious for improving sleep in older adults who have a whole host of medical morbidities. Barb mentioned earlier some of the work that my research group has done is we've improved sleep using CBTI with older adults who have severe osteoarthritis pain, in women who have menopausal vasomotor symptoms, hot flashes. I've worked with people with dementia who have nighttime sleep problems and dementia caregivers. And there's lots of evidence that if you treat the sleep problems, even if you're not targeting the comorbid condition like pain, you might actually improve the pain, or depression or whatever the comorbid condition is, just by improving sleep. We used to think you had to treat what was causing the sleep problems. We had to get rid of depression or pain or whatever, and then a person would sleep better. We now know, in fact, you can target the sleep without targeting these other things, and sometimes the other things will improve, commensurate with sleep improving. I do want to mention especially light therapy. That on that previous slide is the circadian component. So light is the main thing that synchronizes human circadian systems, including sleep and activity. And many older adults are way underexposed to bright light. Bright light doesn't mean necessarily what you think it means. In Seattle, if a person is outside on a cloudy day, they are actually getting more bright light in terms of what the brain sees as light than if they're sitting in their reading chair with just a regular lamp turned on next to them. It seems brighter next to the lamp, right? But in fact, the kind of quality light that affects our circadian clock is more prominent in full spectrum natural light. Or you can get a light box. And I've used light boxes in some of my sleep interventions, and they work great. If you're going to do any kind of light therapy, whether natural or something artificial with a light box, the principles are you want to get as much light as possible during the day, and you want to get as little light as possible during the night. You don't want to be turning on the overhead bathroom light when you go into the bathroom. You want to just have a little night light. You want to try to keep a consistent daylight cycle. And you should be aware that if you have bright light in the morning, like if the first thing you do in the summertime is you get up at 5 in the morning, you take a long walk, that's going to have a tendency to push your circadian clock back so that you have a desire to go to bed earlier. You get sleepy earlier in the night. And if you are getting bright light at the end of the day, then it tends to push your bedtime back. So you want to go to bed later in the night. So you should just be aware of that if you want your circadian rhythm to be in sync with your lifestyle. Things to be aware of with light therapy is if you use bright light right before night, it does have an energizing effect. So if you do have a light box, or you're getting light from sitting in front of your computer screens or whatever, you turn it off and you hop right into bed, it may be more difficult for you to fall asleep than if you have a break time, a lag time, where you'd start dimming the lights and calm down. The sleep benefits from using bright light decay swiftly when you stop doing it. So this isn't one of those things you can get yourself into a good sleep schedule with bright light and then stop. It's kind of a all or none type of a deal. Big light boxes take up a lot of room, so they're kind of awkward, but little ones make it harder to get close enough, get the right dose and right angle for them to be effective. And some people just don't like having bright light around, including people with cognitive impairment. Some folks with dementia are really irritated by having bright light sources available. So if you're working with your clients, you're trying to do things to help improve their sleep. The main thing is just motivation. Clients sometimes have unrealistic expectations. They expect that they're going to be able to sleep like they did when they were 23. Just isn't going to happen, as we saw from that graphic earlier. They may be tired. If you're trying to have them nap less during the day so they sleep more at night, well, then they may be tired during the day when they used to be napping, and they're going to be grumpy about that. It sometimes is very useful to do these kinds of interventions with self-help books, but other times a client really needs someone to be accountable to. They need to be coming back into you or to someone else and say, yeah, look, this is what I did this past week. They are more likely to adhere to these recommendations if someone is talking to them about it. Once you have a person who has mild cognitive impairment, motivation is still an issue, but it's a little bit different because in part, people with mild cognitive impairment, for one thing, in my experience, very rarely are their healthcare providers talking to them about sleep. It's just not the first thing on the agenda when people are getting a new diagnosis of having cognitive problems. And so it doesn't seem like it's very important. But in fact, for a person like that, getting on a regular sleep rising schedule and starting some of these good sleep practices, it's the perfect time to do it before you really start having disruptions in regulation that might be caused by any disease process. But a person with mild cognitive impairment may have trouble remembering what you're asking them to do. So it's more important that if you've got a bed partner, that bed partner be involved and working with the person to help stick with any plan. Many people with MCI have kind of anxiety and depression that are associated with these new symptoms or new diagnosis, and some of the mindfulness and relaxation practices that are a part of cognitive behavioral therapy for insomnia can be very useful for these folks. But I would really, if nothing else, just emphasize keeping a consistent bed rising time, particularly consistent rising time. If you do nothing else, get up at the same time every day, even on your birthday, even on Christmas, that's the single most behavioral, habitual thing a person can do to help their circadian clock. Once a person has actual frank dementia, Alzheimer's disease or Parkinson's disease or others, there are also additional neurological changes, biochemical changes that are going to cause problems with sleep. People with Parkinson's disease, universally, have problems with sleep that include things like nightmares if they're on certain medications, and nocturia, and muscle contractions, cramps, These problems are universal, and sometimes the sleep problems in people with dementia, they present quite strangely. So the person may be, getting up and trying to get dressed to go to work at 3 in the morning or whatever. It's important for caregivers to understand first that this is in part disease process that's driving these behaviors and that they are not under volitional control. So getting mad at the person who's getting up in the middle of the night is not going to help the problem. These are not intentional. Many of the CBTI strategies we talked about earlier can work for people with dementia, though, because people with dementia, not only do they have a brain disease that's causing sleep problems, but they also may have cats that are getting on the bed, or they have, lights shining in their bedrooms, or dogs barking outside, or whatever. So many of the restricting time in bed, or sleep hygiene, or light therapy interventions we've been talking about that work for normal people can work for people with dementia to improve sleep, but you typically need to have the caregiver involved in modulating and working with these activities, because the person with cognitive impairment just isn't going to remember to do it. A particularly useful tool for those of you who have been around the Northwest Geriatric Resource or Education Center for years, you've undoubtedly seen presentations where people from my research group have talked about the ABCs of behavior change. But I just want to highlight them a little bit because they're useful with regards to sleep specifically. And so what the idea of this is, this approach for working with people with dementia was really popularized by my colleague, Dr. Linda Terry and Rebecca Logston. And it has you look at a particular behavior, problem that a person with dementia is experiencing, look at what happened before, that's called the activator, and what happened after the behavior problem, that's the consequence. And what we're trying to do is, if you can identify activators, so what happens before the person gets up in the middle of the night and starts to get dressed and wander, out of the house? If you can change the activator, you might reduce the likelihood that they will get up and get dressed and try to wander out of the house. Similarly, if you can change the consequence, so when my husband gets up and starts to wander, instead of yelling at him and him getting all mad and defensive, and then we get in a shoving match and now things are really bad, by changing the consequence, I might reduce the severity, duration, and even frequency of occurrence down the line. To work with the ABCs with people with dementia around sleep, you need to do some observation, because that's how you're going to find patterns. I often find people who say to me, well, he never sleeps. And if they keep a sleep diary for a week or two, what we find out is actually he sleeps fine 3 to 5 nights a week. But the nights he doesn't sleep are so distressing and problematic for the caregiver, it seems like he never sleeps. But that's interesting, isn't it? If he's not sleeping, 3 to 5 days a week, or he is sleeping, what's happening the other days? Why are some nights good and some nights bad? Is there a pattern? Is it only happening around certain people, or after the families come over for a holiday or whatever? Certain days that it doesn't occur. You want to look at kind of the whole big picture. You want to look at lifetime circumstances. People who have worked night shifts may revert back to a tendency to try to get up because that was their pattern for decades when they were younger. People who have been traumatized, raped in bed, may have trouble being in a single room in a facility, sleeping at night. Some people are biologically predisposed to be early or late risers, and that may be kind of exaggerated as dementia progresses. So it's helpful to kind of look at the whole big context, as well as what's happening immediately before and after the sleep problem arises. And you want to kind of think broadly about all these possible, remember we were talking about medical and environmental and medication, all these historical factors that might contribute to sleep problems. So this is just an example of some of the many factors that might contribute to a person with dementia waking up at night and getting dressed and trying to go to work at 3 in the morning, leaving the house. And some of these we can do something about, and some of them we can't do something about. But even if you can't do anything about it, you at least can be aware of it. So I remember one caregiver I worked with who her husband would get up in the middle of the night and it was driving her crazy. And she finally was so impatient. She said to him, well, what are you doing? He says, I'm on watch. And she remembered then he had been a merchant marine for many decades of his life. And indeed, this was the time of night that he was on watch, when he was on the ship. And she got very impatient and she said, well, go to bed. And he looked at her and he says, well, who are you? And she says, listen, sailor, it doesn't matter who I am, I outrank you, so go to bed. And he did. He went to bed. Now, when she told me that story the next day, she was laughing, and obviously this wasn't going to work every night to get him to go to bed. But it helped her understand, for one thing, that what was causing this behavior was not he was just being difficult and trying to make her life miserable. There was a historical factor that was a part of what was going on. And it also brought some humor into the situation that was badly needed to kind of help him keep moving along. This is an example of something called an ABC problem-solving plan. You can make your own, but it sort of illustrates how you could do an ABC plan around sleeping. So in this case, the behavior is the gentleman's leaving the house in the middle of the night. The activators are he gets up to go to the bathroom, and then once he's gone to the bathroom, he goes to the kitchen and walks outside, and that's when he says he's going to work, and his wife's yelling at him. And so things the wife brainstormed she could possibly change were to hide his robe and his shoes when he first goes into bed. So when he gets up and goes to the bathroom, he doesn't put his shoes on, because that's part of going to work. Or to hang a curtain that can be removed during the day in the hallway. So when he goes to the bathroom and he looks to the right, he doesn't then see the kitchen door inviting him to leave. Or to deadbolt the door so it's a little bit harder for him to figure out how to open it. Changing the consequences would be maybe the wife can get up and when he first goes to the bathroom and invite him nicely to come back to bed rather than wait for him to try to exit and then try to stop him, you know. But definitely whatever, not to argue with him. So the real life lessons about implementing sleep plans for people with dementia is always a question of, is it worth it for the caregiver? You know, in my research, what I found is you have to really get like an hour or more of sleep a night extra for the caregiver to notice. So I can do a study and a person might be sleeping 40 minutes more a night than they were when we started our study. But if it's not more than an hour to the caregiver, it's going to seem like it wasn't enough. And because this is work, if you're telling a person they're not going to sleep during the day, then you have to be keeping them up during the day in some way that before maybe you were doing your laundry or you were taking time for yourself while they were napping. And so some of these bad sleep behaviors that people with dementia get into are in a sense reinforced by caregivers because it's a way of caregivers finding time for themselves. And the caregivers may themselves be having sleep problems that are going to have to be treated separately.
Yeah.
Okay, so how am I doing on time here?
4:40.
And what time do I have till?
You have until 5:30.
Ah, I'm doing great. Okay, so the second thing I want to talk about is moving your body, increasing regular exercise. And I know Emily talked to you about exercise some last week, which was great. These are some of the physical benefits of exercise. We all know that we should exercise more, right? I'm preaching to the choir here. And again, you notice that many of the benefits of physical activities, so lowering diabetes risk, improving aerobic capacity, reducing blood pressure, these are going to reduce risks for cognitive decline just because they reduce the likelihood of the disease process being present that is associated with increased cognitive decline. The thing of it is, as I did with the sleep, I think it's worth just always asking your clients, well, do you exercise? And chances are they're going to say no. In this particular slide, this was a few years ago, but it shows that very few people in the United States are meeting the aerobic and muscle strengthening physical activity guidelines that are recommended by the CDC. And I think the main reason people aren't, there are many reasons people don't exercise, but motivation, as with kind of making changes to improve sleep, is really critical. It's hard to build it into a routine. People don't like to exercise. They have unrealistic expectations about how quickly they can get fit or how quickly it's going to cause them to lose weight, or they may not have any history of exercising. It may be too expensive for some individuals in some communities, or they may not live in neighborhoods where exercise is safe, or they may not have walkable neighborhoods. But, as with sleep, you can you can try to set small goals, something small. Is there one small thing that you can commit to doing in this next week? And if so, how can I help you get there? You know, how can I help you take that one small thing? For people with MCI, again, primary care providers, in my experience, are typically not talking to folks with mild cognitive impairment about exercising. They're talking to them about a lot of things, but not that. And exercise offers hope to people with cognitive impairment, mild cognitive impairment. As Emily talked about last week, the data are mixed on how efficacious exercise can be in improving cognitive function, but they are not all negative. You know, mixed is not the same as meaning there's not a reason to hope that possibly this could make a difference. But people with mild cognitive impairment may forget what they've agreed to do. They may have trouble initiating activity. You really need to emphasize, as with sleep, the regularity, having a regular routine, having an exercise buddy who can help motivate and monitor for safety. This was a quote from one of Emily's slides last week. Again, it says, you know, longitudinal observational studies do show an association between higher levels of physical activity and reduced risk for cognitive decline and dementia. A case can be made for causal interpretation. So I don't think if we are encouraging our clients to exercise more in hope of helping reduce their risk for conditions that are going to cause a more rapid decline, cognitive decline, I don't think that's false hope to be selling to our clients any more than I think it's false to try to get them to sleep. If you're going to be trying to introduce exercise to people with dementia, you have to be aware that, you know, people with severe cognitive impairment often are reluctant to take on new activities. They certainly have difficulty remembering and learning how to do new things. There are many more safety concerns that we need to be aware of, particularly risk for falls, frailty. And family caregivers, or staff caregivers for that matter, may feel like they don't have enough information about exercise and safety. They may already feel burdened with all the other daily tasks they have to do that they don't want to take on the role of having to be an exercise coach as well. So I think the trick to increasing physical activity in people with severe cognitive impairment is to try to make it fun. So what did people enjoy doing in the past? Are there ways that physical activity can be incorporated into the daily routine so it's something that a person with dementia and a caregiver just does on a regular basis? That it's something that it's pleasant. You probably don't want to be thinking about using complicated exercise equipment that needs to be supervised, and we really want to discourage having severely memory impaired people exercising alone, again, for risk that they might get lost or injured. Happily, the ABCs work with exercise too, in terms of if a person is refusing to exercise, what's going on right before they refuse to exercise? What are the activators? What's the context in which that refusal to exercise occurs? And what happens afterwards when the person refuses? How does the caregiver respond? So this is an example of an ABC problem plan for exercising. In this case, the person with dementia doesn't want to exercise. He doesn't like it, and he says he'll do it later. And what happened right before? Well, the husband's looking at magazines when his wife was doing the laundry, and then she comes in and says, it's 10 o'clock, it's time to exercise. That's when we agreed to exercise. And he says, no, I don't want to exercise. And she's sad, and she tries to reason with him, and she says, don't you remember we promised ourselves we're going to do it every day at 10 o'clock? And she tries to convince him, and then she gives up because he's still refusing, and she's mad. So how could you change the activators? How could you change what's going on before he refuses to exercise? And so these were just some ideas that Betty came up with. Maybe exercise earlier in the day before he gets involved in going through his magazines, or have him get dressed in his exercise clothes as soon as he first gets up, so he doesn't have to then change, you know, out of whatever he's dressed in, or invite the son to come and exercise with him sometimes. Sometimes people. I remember one person we were working recently in one of our studies where the person with dementia would exercise happily with a granddaughter, but would not exercise with his wife. So the granddaughter would just come over, and they'd both get on like exercise bikes together, and they'd pedal away, and it was fun for them, but he wouldn't do it for his wife. or how much you change the consequences. And again, always encouraging caregivers to stay calm and pleasant and not engage in arguing and yelling is a good strategy. And perhaps in this case, Betty was going to try maybe exercising in front of him and see if he will then join in rather than just trying to get him started first. Try to cue him with her own activity. The third practice for enriching quality of life across the cognitive continuum is this notion of finding meaning, purpose, and joy in life. And again, I'm sure for everyone who's watching this talk today, I'm preaching to the choir, we all believe in the value and the importance of having things in life that are meaningful to us. And there, in fact, is, again, a growing literature that when you're engaged in things that give you a sense of life purpose and that bring you joy and meaning, that, again, reduces stress hormone levels and inflammatory responses. It increases longevity. You get improved cardiovascular functioning. There's a psychological resilience. So there's only good benefits that can come from it. In the past couple years, what I've seen in the literature is there's increasing evidence on something called positive psychiatry with older adults, including persons with cognitive impairment. And the idea is rather than just trying to find and diagnose the disease or the psychiatric condition or the symptom that needs to be eliminated, it focuses on looking for individual positive attributes and strengths. To look for what are the protective factors, the examples of resilience a person has had in their previous life, and how can we enhance these? How can we build up the good things that people have to face their current situation, not just diagnose and get rid of the problem things? And that, in fact, if we can build up the strengths and the resilience, that a person is going to be more likely to live a good quality of life and respond as effectively as possible to their current situation, including living with a cognitive impairing disease. So when I think about quality of life, I think about there's a researcher called Powell Lawton who is seen by many people to have sort of really established the idea of thinking about quality of life in older adults and in aging. And he had these 4 sectors that he thought were associated with quality of life. And the one on the left, this behavioral competence, that refers to things that people can do in their life to help enhance quality of life. So taking care of yourself physically is one example. Becoming socially active and engaged with other people. Maintaining good time management, even when you're older and you're not on a work schedule that's kind of forcing you into a certain time. So these are very practical behavioral things that people can do to enhance quality of life. I also, when I work with people who are older adults, I try to keep Lawton's quality of life model in mind, but I also personally am very moved by Viktor Frankl's work, where he talks about ways to find meaning in life. For those of you who don't know, Viktor Frankl was a psychiatrist who was in the Nazi concentration camps, and he managed to live through that experience. And in his case, when the Nazis came and pulled him out of their home, they destroyed a book he'd been writing. And he writes in this book that he wanted to live to rewrite this book when he got out of the camps. And he observed that there were in this horrible situation, that there were people who seemed pretty healthy and were doing pretty well, who actually died quicker than some people who seemed sick and frail and you would have never thought that they would survive, and they did. And the difference seemed to be the people who survived were people who found meaning in life. And they found it in kind of one of 3 general ways, either by, they wanted to create or do something. And in Viktor Frankl's case, he wants to get out to rewrite this book that the Nazis have destroyed. Or they want to experience something or encounter someone. So there's people who are going to get out to go find their children, who they've sent away to a safe place. They want to get out and be reunited with people they loved. Or there were people who just are able to face their current situation with grace and dignity, and that gives them a sense of meaning and purpose. So these 2 perspectives for me personally, when I kind of look at people and think about enhancing quality of life, I try to keep those things in mind. What are practical behavioral steps that people can take, like time management and socialization and taking good physical health, and how can we help our clients find meaning in their lives? And again, as with these other things, exercise and with sleep, motivation is really key. You know, each of these sectors in Lawton's model of quality of life, like, you know, physical function and health or physical social environments, they can enhance quality of life, right? But they can also create obstacles. There may be things about the environment that are not enhancing quality of life for a particular individual, and that may be what we need to be working with him or her to overcome. But the thing to remember is that with aging, particularly more advanced aging, change and loss are normal. And so, you know, quality of life is not a static, fixed thing. We are trying to achieve it and find meaning in life wherever we are, in whatever circumstance we find ourselves in now. So Frankel's domains and quality of life, they play themselves out on this canvas of meaning and wrestling with change and loss. And so, again, if you start small, is there, what gets you out of bed in the morning? What brings you joy? You know, what's your reason for wanting to be here today? And, you know, what's standing in the way of you, you know, finding your bliss? And is there one small step you can commit to taking next week? And how can I help you get there? For people with mild cognitive impairment, I think the issues of finding meaning, purpose, and joy in life, there are some very important things I think that are key to this particular population. That includes the stigma, the perceived stigma of having cognitive impairment, of learning that you are not alone and you are not viewed as being of less worth or value than you were yesterday before you came into my office and you got this diagnosis. So getting education about the diagnosis, progression, I think advanced planning for people with mild cognitive impairment is a very important part to maintaining that sense of control. The whole idea of a bucket list, if people have been putting something off, I tell them it's time maybe to stop putting it off. You know, if you really want to take that trip to go visit those grandkids, you know, across the country, well, why does it have to wait for 2 years, you know, when, whatever, you know, let's start doing things now. In people with mild cognitive impairment, anxiety and depression often accompany particularly a new diagnosis. And again, mindfulness and training, relaxation practices can be very helpful in people if they can establish them in their routine. It can help with that anxiety that interferes not only with quality of life, but we talked about it interfering with sleep earlier. And the whole idea of just mindfulness, the finding meaning in life today, right now, where I am. This is a way of finding hope. You know, it's not about kind of finding the ability to be in the present and look for meaning right now. There are research studies that are showing having a greater purpose of life is associated with reduced risk of Alzheimer's disease, mild cognitive impairment, and slower rate of cognitive decline. So again, this is not just a feel-good preposition, but it is also the case that perhaps we may help slow the progression of people's symptoms if we can help them find meaning and purpose. Once a person has dementia, you know, sometimes they're just written off by the world around them. We think of them as being someone we talk about in the doctor's office like they're not even there, sitting next to us, and we assume that because they can't do the things, or they say they don't want to do the things that they used to like enjoy, that they're not capable of enjoying. But I have a colleague who says the one thing that people with dementia retain, no matter how advanced their disease, to the very end of their life, is they know what they like. And that is the basis upon which we can help people find meaning, purpose, and joy in life when they have dementia, even advanced dementia. In my own work, I often relate to this acronym of DANCE, which is presented here. And I'm not going to go through the whole dance, but I want to highlight it because there's a couple of things that help facilitate relationship quality that I think is important for quality of life and finding meaning and purpose. And the first of those things is communication. And the basic idea of good communication is don't argue. Don't argue with people with dementia. Don't try to reason and convince them that what they are saying or doing is wrong and you have the right answer. If you think about it, communication can make or break any relationship, right? And that's true for my relationship with someone with cognitive impairment. And as a disease like Alzheimer's progresses, as cognitive decline increases, communication becomes even more important, particularly nonverbal communication, because people with dementia lose their ability to process verbal information that's coming at them quickly. They maybe can't follow things they're reading. They can't remember or keep track of things people are saying, but they can read body signals. And so you may be saying, no, that's all right, honey, don't worry. I'm not mad that you just spilt that soup on the white kitchen floor I just mopped. But if the way you're saying is with a mean face and an angry tone of voice and you're kind of swiping things up and hurrying around, the message he's going to get is not, oh, it's okay, honey, don't worry about it. The message he's going to get is, I'm mad and you messed up and it's your fault. And that's what he's going to respond to. It's important with people with dementia to remember that relationship building is more important than facts. Incorrect information does not need to be corrected unless failure to correct it is going to lead to some imminent harm or safety risk. And whenever you've got a problem with a person with dementia, you should always look and see if there's been a breakdown in communication. I talk to some people sometimes about being polite. Again, I like acronyms. You don't have to read all the different pieces that polite refers to. You can just think of it as, you know, everything that really matters in life I learned in kindergarten. You know, there's that book out there like that. Well, in a sense, good communication with people with dementia is in part just learning to be polite, treating them with the kind of respect and dignity that you would want to be treated with if you were in their situation. And to, you know, if you just aren't in the mood for being that kind of person, then maybe you need to take a walk around the block and get a little break, or get someone in and give you a little respite so that you are able to do that, because ultimately that good communication is essential to quality of life and meaning and purpose for people with dementia. I love this quote by Maya Angelou that says, people will forget what you said and what you did, but they'll never forget how you made them feel. And I've seen that with folks with dementia, where the caregiver is normally very patient and wonderful, but she has a bad couple of days. And I remember one caregiver telling me her husband looked at her the night before and he said, you know, where's that nice lady who usually takes care of me? When's she coming back? And it's, you know, and she had to laugh because she hadn't been so nice. But he remembered that there was someone, he didn't know her, but he knew that there was someone who was usually nicer to him than she had been the past couple days. Another thing with dementia care is it's really important to try to find the gifts in providing dementia care. You know, it's okay to laugh. People with dementia often do things that are quite funny. And it's okay to laugh with them, not in a mean, mocking way, of course, but often if you start laughing, they're going to laugh too. To look for pleasant and meaningful activities that they can still participate in at whatever stage of disease they are, and that you as a caregiver can still participate in. And to kind of look for the uplifts. Why are you a caregiver? What is the person giving back to you, even at their state? Because everyone needs to feel valued and to have purpose in life, including people with advanced dementia. People with dementia, want to be in interpersonal relationships, shared activities, the same as we do. And they maintain many skills despite their cognitive impairments. And it is important to understand that if you can engage a person with dementia in regular, frequent, pleasant, meaningful activities, it will improve mood and behavior, and it does not matter whether they remember that you were doing these things with them or not. There is a kind of residual body memory, I believe, that can impact mood and behavior over time without the actual, memory that the person has of those events. So how do you find activities that are meaningful or pleasant for people with dementia? So not just any activity will do. If my husband loves shopping and I hate shopping, well, going out on shopping sprees is good for him because he loves it and it keeps me from being unattended at home, so I'm not a safety risk, but it's not pleasant for me. So it's not going to serve the function of improving my quality of life. We need to look at what do people enjoy in the past, what do they enjoy now. Sometimes those things change. Some people do start enjoying things later in life that they didn't enjoy when they were younger. And it's not just fun things, it's also things to enhance a sense of self-worth and satisfaction. One caregiver said to me that it drove him crazy. My wife, she washes the windows in the house 4 or 5 times a day. And I said, well, it's not hurting the windows any. And it gives her a sense of being useful, of participating in the uptake of the house, of being helpful. And that is worth something. That's important. There's tons of books that are out there for you who are interested in kind of coming up with activities to keep people busy and engaged. Remember what I said earlier, not just any activity will do. I love this quote by Robert Davis, that, when I get demented, I want the right to refuse any activity or programming that I don't personally find entertaining. My colleagues Linda Terry and Rebecca Logston developed something called the Pleasant Events Schedule. And this is it's a list of like 20 items, and you can see 4 of them here on this slide, that are rated how often have you done them in the past month, and how much did the person enjoy these things when they were done. And I don't think there's anything special about the list of 20 items on the Pleasant Events Scale. In fact, you can find, like I said, there's books and books and books of all sorts of activities you can do. What I think is most powerful in this particular scale is the frequency and enjoyability ratings. Because if you take any activity, say listening to music, if that's something that when I listen to music, I enjoy it a great deal, and I haven't sat down with my husband and listened to music once in the past month, well, that's interesting. That's a place where there's something I really enjoy that I'm not getting much of, and by doing more of it, that would be helpful. On the other hand, if it's something like I mentioned earlier, joking, if I'm going out shopping with my husband like every other day and I don't enjoy it at all, well, maybe that's an example of something we could find a way to do less of. So I personally think, like I said, it's not the list of activities that's of value in this scale, it's the way of thinking about activities. How often are you doing them? How much do you enjoy them? And are there things you don't enjoy you could do less of, and things you do enjoy that you could do more of? Look for safety bubbles. This is what I call situations where the person's dementia is not relevant. So there's no pressure to remember people, places, facts accurately. So these programs that are happening at the Museum of Modern Art, where people with dementia come and they sit in front of pictures and they say what they think about the picture. There's no right or wrong here. There's no pressure. You don't have to know who painted the picture or what year it was pictured. You just have to be a part of the community that say they like it or they don't. And maybe you don't even say anything at all, but you're part of the community and you're there, and your feelings of dignity and self-respect are maintained. So being with is more important than getting something done. Many caregivers, say, well, I don't want her folding the clothes because then I just have to refold them again. And well, maybe so. Or maybe not. Maybe the underwear could actually go in the drawer folded the way she did it instead of the way that you did it. And, for many people, adult day programs can provide this kind of safety bubble, but not for everyone. And so the idea, I think, of focusing on being useful, being valued, being being more important than getting things done correctly. ABCs are also used with pleasant events. You can use pleasant events to change an activator. So say you've got a behavior problem. Sometimes you've tried to figure out what's going on before that maybe is triggering this behavior and you can't come up with an answer. It might be that if you just start plopping a pleasant event in there, So the person is sundowning at 4 o'clock in the afternoon, and you can't figure out anything about it except it's always at 4 in the afternoon. Well, maybe plopping in a tea time with some pleasant, soothing music at 3:15 will create a context in which whatever that agitated behavior that tends to occur at 4 is less likely to happen because something else, something pleasant is happening instead. Pleasant events can sometimes reduce if you change it as a consequence, reduce a problem's duration or severity. If a person is upset and agitated about something to happen, you listen to what they're saying and you try to understand and you try to reassure them and then maybe try to redirect them to something pleasant, something enjoyable. So bring a pleasant activity, a meaningful activity into as a consequence. And sometimes when you are just completely stuck, you have no ideas, just starting to add pleasant moments throughout the day will help change the whole situation. My colleague Linda Terry likes to say, every encounter can be a pleasant event. Every time you see someone, speak to them, you have the opportunity of it being pleasant or not. And a bunch of those opportunities throughout the day made more pleasant may change the situation in ways that we don't understand because these behaviors do not happen in a linear, causal, simple fashion. So this was a slide that Emily had up last week, her prescription for healthy brain aging. And I put it back up, I stole it from her, because many of the things we're talking about today, getting good night's sleep, increasing physical activity, finding purpose and meaning in life, staying socially connected to prevent loneliness, mentally active, these are pleasant things, meaningful activities. Many of the things I'm talking about are actually on her list. So again, although we don't have the randomized longitudinal trials to show us definitively that yes, if I do 3 sets of leg weights, 3 times a week, that I'm going to have an improvement in my mini-mental score of 2 points after 6 months. We don't have those kinds of data. But we do have lots of data to suggest that these 3 areas, improving sleep, increasing physical activity, and finding ways to maintain quality of life and life purposeful meaning, have many physiological and probably neurocognitive benefits. And again, they're so practical. Each of us, in whatever our clinical practice or situations are, could take any of these and find ways to build them into your normal way of working with people, and I would encourage you to do that. So just to finish things up, again, we're talking about a new way of dementia care. When I started doing this work, we thought of dementia as just a progressive terminal disease, and there was nothing you could do about it except give people medications that would sedate them and they would not be a bother. And now we think of it as a chronic illness that many of us, including our presidents and our loved ones and our most famous and smart and talented people are experiencing, and people are rising up heroes and heroines to provide care and enhance quality of life for them, and that's what we're called to do now. We're called to treat dementia as a way of life that people have to live with, and we're going to try to help them do it in the best way possible. Many people are going to live with this disease for decades now that we're diagnosing them so early. So we have lots of opportunity to try to really change the way we think and they think and their caregivers think about living with this disease. So that about ends it. I just want to do 2 things. I want to acknowledge my research team that I've been a part of since I came to University of Washington back in 1991. Special thanks to Linda Terry, who took me on as a lowly postdoc, without whom I would not be here today. And then just to reorient you to the appendices, I'm not going to go through the appendices, but just to remind you they're there. There's information about insomnia assessment and treatment. There's a few dementia treatment and assessment resources that have been perhaps more useful for other people where I've given talks similar to this than they are to you, but I left them in. And then just some citations if you're interested in any of the research evidence base behind the exercise, sleep, and quality of life topics I've been talking about today. there's slides that just show you the primary citations, and you can look those up if you are interested. So that said, I'm just about right on time to finish. So I think Barb was keeping track of questions, and that's good because the printout of them is really teeny tiny here, so I wouldn't be able to read them anyway.
So these kind of came in at various parts of your. The first one is a person who recently learned about a sleep apnea device that does not involve CPAP. It's a mouth-jaw device that relaxes the temporomandibular joint, pulling the tongue from the soft palate. I wonder if this is increasingly common and if this device will increase compliance. Have you heard of it?
So the question is an alternative to CPAP for people with sleep apnea, and you're talking about a mouth device. And yes, I have heard of that. And if one is diagnosed in a sleep clinic, they say to the people who gave them the diagnosis, there's no way I'm going to use a sleep machine, or they take the CPAP and they discover they can't use it and they go back, they often will be referred to like a dentist or another kind of profession within a sleep clinic for an evaluation for one of these mouthpieces. I saw something on the news just like last week or the week before where they've now got like a little heart, it's like a pacemaker-like device that they can implant under the skin. And what it does is people turn it on at night when they go to bed. And what happens with obstructive sleep apnea is the soft palate muscles relax and they block the breathing passages. And what this device does is it detects when your airway has been shut off, and it zaps your soft palate with like a little zap, which causes you to open your mouth and breathe. And other than waking up sometimes in the morning with kind of the top of your mouth a little bit sore, it's like, which seems like a really great device to me. Unfortunately, it's like $20,000 and most insurance companies don't pay for it. But it's another example of, I think, people are aware that there is a pressure to come up with alternatives to CPAP. CPAP works great, but not everyone can or will tolerate it. And it's been a big money maker for pulmonary clinics, but I think people are looking into alternative options.
So someone has mentioned macular degeneration and the fact that it's always dark for a patient who has macular degeneration. Are there any ideas for training a patient day versus night in that situation?
Well, that's a really good question, and that's not easy. It's similar to people who are, blind from a young age, where circadian rhythm dysregularity is quite rampant. And in that case, there are medications that can be taken. Oh, the question was, I'm sorry, I forgot to repeat the question. The question is, if someone has macular degeneration and they can't get in light, what can be done to help them establish a regular circadian rhythm? So since they can't get access to light, there are medications that are available for persons who have a condition where their circadian rhythm is caused by blindness. Some of those might or might not be appropriate for older adults, given their side effect risks. I think regularity in schedule can still be useful, particularly if a person lives with someone that can make sure that they're getting up at the same time and that they're stimulated during the day. So even though they're not getting the light in that's setting their clock, something called Zeitgebers. And what that means is it's things in the environment that cue our circadian clock, and light is an important part of that. But clocks and activities at the same time every day and getting up at the same time of day, these also are cues that help improve our circadian rhythm. So that would be something I would also recommend for people who are having trouble getting light in.
And Wolf Point is asking if we could get a printable copy of the checklist on slide 74.
Sure. You can get a printable copy of that. I would say if you want to email me, and my email's on the cover of the first page, I would be happy to send you whatever you want.
And I'm sorry.
Oh, the question was.
I accidentally clicked off of the slide you were on.
Oh.
Just to let you know.
Well, and I've been watching the slides moving around. I thought, gee, it's magic.
I was trying to see if I could find slide 74, and then I was, or like if I.
74 is actually Emily's brain aging thing.
Or I think it was slide 77, maybe.
Well,
but.
I can get that there. I know where it is.
Oh.
So the question is, I forgot to again. So could you get this healthy brain aging checklist? And I'm sure Emily would give me permission to send it to you. And so I'd be happy to do that. Just drop me an email if there's this or anything else that you want to see, or I'd be happy to follow up with that.
Other questions in the room?
No.
In the beginning of the lecture, you mentioned about the maybe the pathology of dementia just start in the early age, like 20 or 30. So we can detect the change in early life earlier. So I wonder how much developed our science about this topic. So it's really interesting. So do you know?
So I think the question is, what do we really know that's leading us to believe that people in their 20s and 30s are starting to develop the neuropathological signs of Alzheimer's disease? Because obviously most people that age aren't dying and we're not doing autopsies on them, so we're having to figure it out other ways. And the way they're coming to this conclusion is in part, I think, through animal model studies. So they're looking at, they have, for example, mice that have been bred to be Alzheimer's mice. And they can look and they can sacrifice animals at younger stages as well as when they show the symptoms and look and see what kind of changes are happening pathologically. So I think that's one way it's being done. Another way it's being done is part of that research protocol I was talking about with the National Institute on Aging and the Alzheimer's Association, where they are looking at select biomarkers. So for example, they're looking at amyloid levels in cerebral spinal fluid. And these kinds of things, in some cases it's blood tests or it's cerebral spinal fluid tests. These tests are just for research purposes. So you're not going to be able to go to your doctor and say, give me a spinal tap and tell me if I've got amyloid in there and I'm going to get Alzheimer's in 20 years. It's not, they're not being used for that way, but they are being used to try to get a sense of when you have younger asymptomatic individuals, are they already in groups, and then these people aren't yet anyway being followed for 40 years to see if they go ahead to develop the problems, but are we seeing some of these signs that in later life we associate with Alzheimer's disease? Are we seeing them in asymptomatic people younger? And the answer is, and it seems that we are. So that's leading us to believe that probably these diseases are developing over a course of a lifetime, not just suddenly. Oh my gosh, a thought just went through my mind and then it slipped away. I don't think it's Alzheimer's. If it comes back, I'll.
Wyoming is saying as far as circadian rhythm, with using sounds work, for example, birds singing during the day, or maybe frogs or crickets at night.
Well, that's a good question. The question is, would using sounds to help establish cues for circadian wake-night be useful? And the example was like birds during the day or frogs and things at night. I would say maybe. I haven't seen any studies that do that. What I have seen were studies, though, where they showed that older adults who were in regular social programs that were at the same time of day on a daily basis, that having them that kind of consistent daily activity, now these weren't physical activities, they were socialization activities, had better sleep than people who were not. And to the extent that sounds could be something that would be associated with daytime activity, and if it was done on a regular basis, that might be very useful. I guess the trick would be to find sounds that were clearly day and sounds that were clearly night. So transitioning from day to night with birds to frogs, I'm not sure would be a clear enough difference to signal this is day and this is night. But it might depend on the individual too. And again, remember, all this is completely individualized based upon the history of the person, their current psychosocial context, you know. So, I mean, for me, my circadian clock currently is totally set to NPR having bird notes come on at 6:33 in the morning on my national public radio station. It's like, it's morning when bird notes come on. So maybe it will work. Anyway.
I don't know what bird notes is.
Any other questions?
What does that mean? PWD.
Oh, okay. So the question is on the handouts where I say PWD. What does that mean? And that means persons with dementia. And I appreciate you pointing that out to me. I try to not use acronyms without defining them, but I don't always remember. So thank you. Any other questions? If not, I want to thank you all with your patience with my sitting in front of this laptop. Well, I don't know.
It worked great. Great idea. Thank you very much.
Thank you.